I'm Dr. Alexandra Carter. I am a neurologist and epileptologist and the medical director of the Saskatchewan Epilepsy Program. Epilepsy is the tendency towards having unprovoked seizures. So it's a seizure disorder, sometimes we'll refer to it, but really if we've had two unprovoked seizures more than 24 hours apart, or if we've had an unprovoked seizure and there's something that shows us that the tendency towards having more seizures is there, so an abnormal EEG or something structural on our brain imaging like our MRI, then we can say that risk of having another seizure is high enough, so about 70%, that we know we need to start a medication to prevent seizures. When we think about epilepsy though, seizures are the first thing that come to mind, right? That's really all we think about, but it's really important to highlight that it's about so much more. So with epilepsy, we know there's a lot of comorbidities, so depression, anxiety, especially with certain types of epilepsy, like temporal lobe epilepsy, are really more the rule and not the exception. And then we see a lot of quality of life impact. So because when somebody's having unprovoked seizures, we're not able to drive, we're worried about having a seizure in a place that may be dangerous, that leads to injury, or that puts our loved ones in danger. So if you're a young parent and you have a young child who needs to be supervised, or bathing them, we need to make sure that we have another adult who can supervise. So really taking away some of that caregiver role and that independence, I think, is a huge thing. The unpredictability of seizures, I think, is very important to know as well, because you may feel great day to day, but you know that there could be a seizure that happens at any time if you miss a dose of medication or if some other triggers come up for you, and some of those are not avoidable, like stress, sleep deprivation. All of us have some of those nights where we're not able to sleep as much. We know with epilepsy as well, depending on the type, there can be a lot of trouble with memory, for instance. We mentioned mood can also be affected quite a bit. Sleep in and of itself can be disturbed by seizures and just by having the tendency towards having seizures. So really it's more than just the seizures itself, it's really overarching and affects a whole person. Seizure is a transient loss of awareness, basically, or a transient alteration in a person's day-to-day functioning. So that can be as subtle as a quick loss of awareness or alteration of awareness. Sometimes not even. Sometimes people will have their aura, and we think of that as a warning for a seizure, but really that's the beginning of the seizure, just very, very, very focally, or very, a small part of the brain that is activating. So somebody might just have a little rising up kind of nauseous sense and a deja vu, and just kind of feel like that really dreamlike state where they're feeling not quite right. That may or may not progress into impairing their awareness, where they're confused or totally amnestic, like they don't remember what's happened at all, and they wouldn't know they'd had a seizure unless somebody around them was able to tell them about that. And that can progress further all the way into what we'd say a bilateral tonic-clonic seizures. When we're talking about the terminology, those focal seizures are what we used to call petit mal seizures or petit mal seizures. And then later on, we redefine them to being like simple partial seizures or complex partial seizures. And then the tonic-clonic seizures are what we call grand mal seizures. So really, it's a vast spectrum of changes that we can see, all the way from the subtle, where it's maybe misdiagnosed as panic attacks initially, all the way into something that's more obviously seizure with convulsions that are happening as well. Anti-seizure medication, that's really our mainstay. So when somebody first comes in to see me in our rapid access clinic and we say, yep, this looks like you have a tendency towards having ongoing seizures, we'll offer them an anti-seizure medication. Like I said, the vast majority of people, 60 to 70% of people, will be well controlled on their first medication that we try, or sometimes their second medication if we need to try a second medication, which is great. However, if they're not responding to those medications, and we're kind of looking like we're more in that 1/3 of people who don't respond, we say you have drug-resistant epilepsy or medication-refractory epilepsy. And in those cases, we look at surgical options. So if the seizures are coming from a particular region of the brain, and we can figure that out by characterizing the seizures on the EEG a little bit better with video, then we can offer a resection or take out that part of the brain that's causing the seizures. Sometimes somebody is not a candidate for a resection because either the seizures are coming from multiple spots, or they're a primary generalized case where the seizures start in the middle and go to both sides at once, and there's not really a spot that we can pinpoint as to where the seizures are coming from. And in those cases, that's where we would offer something like a pacemaker for the brain or neuromodulation. So that's a vagal nerve stimulator or a deep brain stimulator. One exciting treatment that is coming to Canada that's been available in the States for quite some time and in Europe is the responsive neurostimulator. And that looks like it's got some more efficacy. And we're just seeing this year, I think we've had about 5 cases in Canada where we've had it. So that's another option that we offer as well. If you're coming across somebody in the street and they're having that convulsion, first and foremost, making sure they're in a safe place. They're not going to injure themselves by rolling into something that's going to injure them or hitting their head on the floor. So if you have something like access to something soft like a pillow or a jacket, being able to put it under their head, making sure that their airway is clear, so they're not, having any obstruction of their airway, their head isn't into the pillow. We do see that sometimes, overnight especially, is something that we worry about. So making sure that they have access to air, and then if there's any, bleeding or foaming from the mouth or vomit that's coming, that it's going to clear that airway so that we're having the head turned down towards the side, so into the recovery position first and foremost. Seizures tend to abort and they just stop on their own after about 1 to 2 minutes most commonly. If that seizure is lasting longer than that, that's when we need to be calling for help or going into emergency. So if that seizure is lasting longer than 3 to 5 minutes, we need to be calling 911. Or of course, if there's something else that, the person has injured themselves or they look like they're turning blue if they're not having, oxygen, usually that's more with a prolonged seizure, then we need to be calling 911 as quickly as we can to get some help. It's also important not to try and drive the person into an emergency room yourself, because if we call for the ambulance, oftentimes they'll have medication that can stop the seizure sooner. And they can support them with an airway as well, as opposed to if somebody's having one, don't try and get them to the hospital yourself, call for help. If it's a focal seizure and you're seeing somebody having, the loss of awareness, or they're confused, or they've had a seizure and they're agitated and, sometimes looking even aggressive, making sure again that they're in a safe place, other people are safe, and they're not going to be able to be injured. You don't need to necessarily stop them from doing anything, but monitoring them, making sure that you're able to, if they are able to walk them to a safe place where they are, if they progress into a big grand mal seizure, that they're not going to fall and injure themselves with that fall. We're a provincial program, which means we take referrals from all across Saskatchewan, and as the epilepsy program, we do see people when they're first diagnosed, so at the beginning of their journey, all the way to hopefully cure with resection. That said, because we are a specialized referral program, we tend to see people who are more drug resistant, and that's because we need to bring them in to have monitoring done. So that would be through our seizure investigation unit, which is based at RUH, where we characterize the seizures, make sure that they are seizures, and if we're thinking about surgery, we can see exactly where the seizures are coming from and plan for a surgery. We're a multidisciplinary team, so we have our nurses who help us, our neuropsychologists, our neurosurgeon, and we're looking at having more people support us all the time. We definitely need more. First and foremost, close to home is Epilepsy Saskatoon, which is our chapter of the Canadian Epilepsy Alliance. That is a patient support group that is run by patients. Lori Newman is the president of Epilepsy Saskatoon, and she's amazing. So it's people who have lived experience, who know what you're going through, who know what the side effects of medications can be, and can offer some experience into, I had a neurostimulator and I'm doing well with it, or just kind of being able to offer some of that. They meet about once a month. If you're looking for more resources in terms of education resources, I would point you towards the Canadian League Against Epilepsy or the International League Against Epilepsy, and they have great resources both for physicians and patients.